welcome back, everyone, to another fun episode of Trying to Keep Up, where Allison and I do our best to keep up, and really our best is not the greatest all the time. So we bring in special guests who help us out, and today's special guest is the great Matt Trachtenberg, and Matt and I worked together at FDA way back when in cardiovascular devices, but I'll let Matt introduce himself and tell us where he's at today, and then start us off with the joke. So, Matt, you're up.
All right, thanks so much. It's great to join you. Matt Trachtenberg, I'm a Senior Director of Regulatory Affairs at Tempest AI, and everything I'm saying today is just strictly personal capacity. And I just celebrated my 2-year anniversary there. If you haven't heard of Tempest, they are largely in the IVD space. They're doing a lot of sequencing. They're doing some companion diagnostic work. Some of it's in the LDT space. Some of it's actually going through the FDA. And the things I work on are a little bit different. It's more in the we've got some cardio devices. We're doing some interesting AI work using ECG signals to help predict different heart disease conditions. And I also do a little bit on the digital radiology side of things. And before Tempest, I was at Becton Dickinson, and I was there for about 9 years. I worked in specimen management. So those were our blood collection tubes, which are handled as IVDs. And then before that, I was in the diabetes care group, doing pen needles, insulin syringes, but also some more complicated insulin patch pumps. And as Mike mentioned, I was at the FDA for about 4 years and learned a lot there. I had a really good experience there working with Mike and the rest of the team there at the Division of Cardiovascular Devices. So if I'm kicking off the jokes, what is the only sea creature that can write a 510K submission?
Man, I should be able to get this one.
I'm going to say I don't know.
Yeah, go for it. Tell us.
It's the E starfish.
Oh, that's a good one. And I like that one because I think you made that one up, and that's a good. I think that might be the first original joke on the podcast. Good one.
Oh
Um,
gosh. Do you
I
want to go
also
next,
have,
Milo?
yeah, I will, because I also have a sea creature, and we did not talk about this, but I also have a sea creature joke, and this might be the dumbest joke we've told on the podcast so far. So, how many tickles does it take to make an octopus laugh?
Octaticals. Something.
So, you might think it would be 8 tickles, but it's actually 10 tickles.
Tentacle.
Tentacles.
Dang it. Gosh,
Yeah. Yeah, we really busted out the popsicle stick jokes for today.
gosh. So, I don't have a sea creature one, but I have an escalator one because I went to Comic-Con last week and
That was
it's at the
just
San
last
Diego
week.
Convention. Yes. And I had so much fun. Dressed up as a lot of different characters because I went Friday and Saturday, and there was an escalator that was broken, and there's this little kid. This is overheard at Comic Con. He says, "What does the escalator say when it's broken?" And the mom was like, "I don't know," and he's like, "Nothing. It's just stairs." So overheard at con.
It's
Overheard at the
it's an
con. Yeah.
old Mitch Hedberg joke of it's not broken, it's just stairs. Thank you for the convenience.
It was a pain though, because man, walking around in some of these like costumes, and my daughter had this thing on her foot. I was like, oh, I could really use an escalator right now. But anyway,
Um, be on the Comic Con theme before we get to real things. I think our family's going as like the people from Dungeon Crawler Carl this year, and I don't know if you've read or listened to any of those books, but they are hilarious. And we're both me and my wife are like plowing through the series on audiobooks, and we're like, this is gonna be hilarious because our daughter can be Donut the cat, and I can be a dinosaur, and Carolyn can be Carl.
okay, you're the second person I've talked to about this series this
Yeah.
week. Because I had Blythe Caro. I don't know if you know, she's the writer of the Device Files. I had her on my podcast and she was like, "Do you know this like dungeon crawlers?" Anyway, now
It's extremely silly, but it's a lot of fun. Matt, are you aware of
Yeah.
it too?
Yeah.
Yeah.
I listened to all the audiobooks. We had a stint where my one
I
year old
need this.
was sleeping like maybe 4 hours a night, and I would be up with
Okay.
him the whole time. And I was just like, I have to listen to something. So I went through all of those audiobooks. And the audiobooks are awesome. They do a really good
They're
job with all
hilarious.
the. Yeah.
Yeah. I'm doing the audiobooks right now too, and I think I'm on book 5, and Carolyn's on book 4 because we share an Audible subscription, so we can't be at the exact same time, or else we'll mix up where we're at. So, yeah.
Uh,
So this is your plug for everyone in on our medical device regulatory talk to go listen to Dungeon Crawler Carl.
dungeon crawler Carl. Okay.
Yeah.
Now that I've had multiple people tell me this is a sign that I need to do this. Let's dive in, shall we?
Yeah.
It's been a busy yet not busy. I don't know. Some weeks I'm just like so many things happen, and then I'm like, but did it really? Like, is anything, or is just are people just talking about stuff? Um, do you want to talk about the new de novo?
I think Matt, you put this one in if you want
I put
to
it in
talk
there. I
about.
can give you the big picture, although it's just, the way it's written is a little complicated. But there's an amazing video on the website. So this was Auris Health, and I think they're part of J&J. It's called the Ottava Robotic Surgical System, and they got this de novo, I think, around July 21st. And then it says that it's intended to assist in the accurate control of endoscopic instruments, endoscopes, and accessories for visualization and manipulation of tissues, and then they include a bunch of different kinds of instruments. And it's actually the way they are defining it, the type of device is a integrated operating table electromechanical surgical system, which didn't really mean much to me. If you look at a picture or an image, it's essentially an operating table with maybe 4 different like robotic arms that I guess can have different
Oh,
tools, and it can, like, the arms are connected onto the table, and I think the table can even move to some degree during the procedure, and it's all to help with minimally invasive and laparoscopic surgical procedures. So it sounded very interesting.
I'll
It's
have
by
to
our
pull up
friends at
the
J&J, huh?
I'll have
Oris
to pull
Health,
up the
friends at
video
J&J.
because
Yeah.
I was curious because like we have robotic surgical, from Da Vinci and on, and I was kind of like, why is this a de novo? But this
That was my
sounds
question too. Yeah,
this
like
this
what is
sounds pretty. This sounds like it's going to be more Doc Ock kind of like bunch of different things coming at once. So I'll have to take a look at that. That sounds cool.
That's totally what came to my mind too, is Doc Ock,
Yeah.
and like then I was like, oh,
We're
your
full on
octopus.
Comic Con
We are
mode
caught
for
like
this.
yes, we are. And your octopus joke was on brand for this. Yeah, I was reading about this yesterday, and yeah, my first thought was like, how is this a de novo? And then I was like, um, yeah, maybe there were different questions of safety and effectiveness that no good predicate could hold it. And then stupid fact of the day, the product code for this is NAY,
That is.
NAY. You're welcome. The other one that came out was SIT. So Sports Suite was SIT, and then there was another one that was SIR. I was like, I'm kind of loving this. I wonder, is WTF a pro code? I'll
Not
look it up
yet.
right now.
They go in order.
But
We haven't got.
there's ones that are. Oh my gosh, I was about to say something really stupid. I'm gonna back up. Um, you're right. I was like, Q is later than S, and I was like, no, that's not true. But I thought there were ones that they had that were like
I don't
ZZ
think.
something. Are
I
there
don't think
not
we've got.
really?
I don't think we've gotten to the W's yet.
Okay. Okay. Stand corrected. Let's talk about our PMA. This one is super exciting for many reasons, but do you want to talk about that one too, Matt? I think
I think I
he's our
put it
star
in
this
here.
week for like
I was
putting
just
things in.
nervous and trying to figure out how to prepare for this. The new original PMA that I saw listed there was from Freenome. It's a simple screen CRC. So it's meant to use circulating cell-free DNA from either plasma or whole blood, and it's meant for colorectal cancer screening. And it's not, I think, to be used just on its own. It's not to replace a diagnostic colonoscopy, but I think it's a screening tool so that if you test positive, then you say, okay, the blood test was easy, now I really should be motivated to go in for the colonoscopy, which is probably not as easy as a simple blood draw, but you'll be motivated to get it after this test, I guess.
I was kind of,
Yeah.
when I
Go
took a
ahead.
look at this after you put it in there, I was kind of bummed that it said 45 and older, only because much like mammograms aren't covered by insurance until women turn 40 unless there's a genetic thing. Colonoscopies aren't covered or even recommended by for men until after 50. And I'm like, but there's those are like lots of women get breast cancer in their 30s and lots of men get breast colon cancer in their 40s. I'm like, couldn't we be doing more things that are covered by insurance, like pre-screening to get to those things? And I was this is very cool because it's still 5 years earlier than the 50, but I was like, man, it'd be nice if this was like 30, and like get some peace of mind for some of this stuff. But I do like when they start doing the non-invasive because um, at least for colon cancer, and I know for other like uterine cancers and things like that, the invasiveness of the tool, even the scope, can like slightly increase the risk of if you do have cancer, making it metastasize because you can like rub it and spread it, which is
Right?
weird. Yeah.
I was super excited to see it. I think 45 was probably their starting point. I hope that it's going to be like because it's a PMA, they're gonna probably have supplements ready to go. And I'm I like seeing stuff like this. Like people are so scared of getting their colonoscopies, or they're like, it's a pain. Like it's gonna be multiple days. They have to get anesthetized many times. And even if it's like, again, this is not replacing your colonoscopy, but pun intended, if you are able to go and get your blood tested or get that started earlier, like I just big win for patients. Nice job, Abbott, because Freenome I think Abbott saw that as a good investment, and so I think they now own Freenome. So
Matt, is Tempest doing cancer diagnostic stuff? You mentioned that you guys were in this space.
Yeah, they're doing a lot in this space. It's there's DNA, there's RNA, there's cell-free DNA. So all the development is in different phases work, but they've got a lot of interesting stuff going on. And I'm seeing even we have a whole Slack group with all the different press releases from other companies, and just seeing what's happening in this space about even stuff like methylation and just some of these more advanced diagnostics that are coming from all over are really exciting to see.
That's cool. I was actually just talking to someone, a student or a postdoc at University of Pittsburgh last night. Uh, Shout out to our local RAPS, local networking group, hosted an event, but they were doing DNA methylation research and things, and I was like, I remember hearing this was a thing, and now seeing like how far advanced it has become since I took that class in college, right? You get touched on it and like, oh, man, they're doing cool things with it. So
I think I've hit the age where things that I learned in college have either been like disproven or it's like ancient history. People are like, "Oh yeah, that's really old." I'm like, "Oh."
I've been having the recently though, and we're all pretty close to the same age. Matt's a little bit younger, but that the stuff we learned about in like biology in like high school or college is now like actually hitting. It was like the cool new thing, but now it's actually hitting the market because like we learned about CRISPR in high school. Like it was the thing now, and now it's like in the news as like this brand new thing. I'm like, I was in high school a long time ago. This was a thing back then, but it's taken that much time to make it like a real commercially viable rather than like a academically viable thing. And I thought that was kind of it's a good marker of like how long science can take to get from a good idea to an actual like we can use it now.
Let's can we talk about orange juice for a second?
I saw you put this out there. I have no idea what it is. What are we talking about here?
If you go to fda.gov right now, the top the banner says recall alert. There's an update on the cyclospora outbreak available here. So you can click on that link. And then there's the whole screen is taken up by modernizing pasteurized orange juice standards. Um, and so, yeah, they're talking about updating the over 6 decade old standard. They're slashing unnecessary regulatory barriers that have forced US markets to depend on foreign citrus imports. And I just wanted to make sure that everyone knows that this is the most important thing going on at FDA right now. Anyway, I'm going to leave that there. Let's move on to so enjoy your orange juice. It's going to be from the US. The I know this is also so I'm clearly going into food, and then I'm also going to go into CBER for a second because there was a really cool press release, and I love blood and people working on like blood and what are the words organ transplantation and just trying to make it easier for people to stay alive. And CBER came out with the first ever freeze dried plasma, and this was just super cool to read about. It's like a lyophilized, um, as I understand it, like a shelf stable plasma that it's in all the different blood types. So you have AB, group A, and it's a lyophilized, so powder plasma product derived from a single unit of fresh frozen plasma collected from FDA licensed blood establishments. And so it's one of those things that if you're in an environment in a combat zone or disaster or rural setting or other places that cannot keep your plasma at the right temperature and whatnot, there's now a powder for that. So
See.
yeah, there's conventional frozen plasma. If it's unavailable, now there's lyophilized plasma. So just cool science when you see stuff like this and you're like, this is going to save some people's lives that might not be able to have access to frozen plasma. I love it. So I can't remember who did it. Esplaz is the name of it.
Very cool and wild that that works.
I
It's
know.
like just add water, plasma.
It's like magic. Yeah. Uh, anyway, nice job, FDA. And nice job, industry. Let's move on. So, Matt, why don't you talk to us about using AI?
Yeah, so this was less AI medical device. It's more as someone in the regulatory field. I'm curious to pick your brain. How are you using AI? Are you using it? Are you comfortable or uncomfortable with it? I'm kind of the AI guy kind of within my regulatory team, and it kind of reminds me back when I was at the FDA. We had these smart templates, these memos we were working on with like Nels and uh, you click this box and it auto generates a deficiency, and I think they've probably taken that even further with eStar. But I had a lot of fun playing around with that, and now I'm trying to do some similar stuff here. And our company is very AI forward. Um, they give us our own like special platform where you can custom build your own agents, and you can dial in
No way.
you know which agent you want to use and what's the prompt, and you can make your own custom collections where it's like, okay, here's all the FDA regs and guidance documents. And then I found a way recently to use Claude Code, not for coding, but to do all this more advanced stuff. Like I can have it every week check all the different regions that I'm interested in for any new like changes to the regulations, new guidance documents, and then it can kind of auto sync that into this collection I have, so that my regulatory agent um, has the latest and greatest information. But I'm still kind of a little shy about using it too heavily. I feel like it's almost like a junior regulatory associate or an intern who has a ton of time on their hands, where I can say, here's a task, go dig into this super deep, give me something, but then it's okay, let me double check like everything and make sure it's really accurate before I actually use this for any real purpose.
I'll answer from my end. I'm kind of a troglodyte and not intentionally, just like time to like learn how to do it has been tough, but we've been starting to do kind of similar to what you are talking about, Matt, and like not, I haven't been able to play around with it, so I've been having like other people kind of help me out with how do I make my SOW processes easier, or regulatory intelligence, just staying up to the news, or like prepping for meetings and, tell me 10 things about the potential new client I'm about to talk to, that kind of stuff. Trying to integrate more. I feel the same way as you do on I feel secure in my job in terms of regulatory intelligence of like a regulatory strategy from the agents on what they output. It's kind of like day two of Wikipedia when you were like, hey, everything on here might be BS, but some of it's really good. So like verify everything, cite and verify, double check the sources on things. So we kind of treat it like that if we use it for any sort of writing. I I also our clients use it a ton to like send us drafts and have us review it. And I probably said this analogy on the podcast before, but my uncle's a plumber, and he said the best thing that ever happened to him was YouTube, because people thought they could do their at-home plumbing themselves, and it just made way more business for him because they'd make a small thing 10 times worse. And I feel like that's they're getting people are getting like good ideas, but which are like close enough to look good, but they're actually like wildly wrong, and so we're having to fix a lot of the AI generated like submission type work, but I think it's like really good at preliminary type stuff. So we're trying to use an organization type stuff too. So trying to utilize more of it.
There's a ton of nuance in this field that you can't really trust these agents for just yet. You need someone with a ton of experience who can actually apply that and make those real decisions. That's for sure.
Allison, you're on mute.
Ha, just chatting to myself. I feel like people send me stuff and I'm like, this is all AI, right? And they're like, yes, yes, it is. And I'm like, okay, just that's fine. I at least know that when I'm going into it. I'm fine if people want to take the first stab at stuff, right? Because I'm like, hey, it saves you time, saves you money. And as
Sometimes.
long as I sometimes, right? Yeah,
Yeah.
as you said, like maybe they've made it 10 times worse, or they've done the submission and then FDA's come back and you're like, oh, this is not pretty. Um, so I don't use a lot of AI. I guess even for like with blue stocking health stuff specifically, I want it to be so authentic, and I want it to be that I don't know, used my creative touch on things. Um, yeah, so I won't use it for the content, the media type stuff. I will use it to help me come up with bios for people. I'm like, oh, I need a bio for a speaker that's going to be presenting to San Diego Regulatory Affairs Network. And so I might use it to like say, hey, here's the person's LinkedIn, here's some information. Can you write me a fun bio about them? I love so with my work at Duval and Associates, we have licensed with Nyquist AI. So
Yeah.
that is the database that we use. Michelle Wu, shout out, she's awesome. And also it's helpful, right? Because there's stuff
Yeah.
that I find in there that I'm like FDA would not be able to find, and so we've been able to say, well, here's a similar technology that you cleared back in 1990, but uh, FDA might not realize it, and it's a. I think Michelle's told me once. She's like, FDA databases are built for transparency, which is questionable sometimes, and a lot of the AI tools like Basel Systems, Nyquist, and these other tools are built for discovery, right? And so really being able to understand like what are good predicates, what's maybe what testing what have other companies done in order to submit their files. So yeah, that would be my
Yeah.
take.
We we use Nyquist as well, and used to use Basil, and honestly, like both are great products. It was a price point difference, I think, on those. But Michelle's putting together a great thing at Nyquist, so definitely agree there. And to your point on creative stuff, we do tend to use like to put together quick slides, but I don't love them. I
Hmm.
don't love them for my own personal presentations. They're solid for like corporate decks, but it's like everything, it's curving everything to like a B minus. Because it's like, yes, everything looks the same and it looks nice, but it's boring. So I find that it's like, okay, this I want my slides to be me when I'm presenting, but if it's for like a financial deck and the idea is for it to be boring, then AI does a great job.
Yeah, fair.
You know,
Speaking of creativity, a lot of people, did post something about 513Gs yesterday on LinkedIn about a flowchart about 513Gs, and someone asked me if I used AI. And not that it was a very creative thing at all that I put together, but it was not. It was me using Adobe and Microsoft Paint.
I actually assumed it was AI too, to be honest.
Really?
Yeah, I was like, you gave it like the flow chart and said make this because of the amount of like,
No,
yeah,
that was
you have too
that
much
that
time
was
on your
from.
hands. That that flow chart could have been a robot.
Dang it. Dang it. But it's my font. It's like the blue
That's true.
stocking house font. So
That is, it was
I
branded.
had to, it had to be on my brand.
Yeah.
Um, so anyway, any 513G, I love hearing people rant about it. So any, any thoughts?
I, I've got thoughts. I was actually like slightly. I was like, Allison, you're not even going to tag me in this. The amount of times I've just
I know, I'm
bitched about
sorry.
the 513Gs directly to you. Before you wind me up like a toy monkey, Matt, have you had to do any 513Gs since, or even remember reviewing any?
oh gosh, I don't think I've really reviewed any or done any myself. There was a time at BD where we were partnering with some smaller company that had some IP we were trying to incorporate, and they had done a 513G for something, and it seems like it was useful for them. But I just feel like there's a lot of other horror stories.
Grace says, I have a hard time not doing a 513G when FDA directly asks for it, which has only been twice, one pending. I'd love to know how many days you're in, Grace. I will say there have been a handful of cases where it has been useful, or a company has come to me and said, "Oh, we did the 513G and we got the classification information, and now we're here to talk to you about a pre-sub and the 510K." And I'm like, "How did you get that? That's amazing." And so maybe it's because I honestly they didn't have a consultant, the one that I'm thinking of, and I was like, maybe FDA was just like, "Oh, you guys, we're gonna help you."
I Grace said 4 months in and already has had questions. I think the fastest response I've ever gotten in a 513G where we've been forced to do it, and that's typically from like NIH funding. Sometimes their grant advisors will force a 513G, was 14 months. I think was the fastest we've ever gotten a full turnaround to decision. Um, and Grace has had better luck. My kind of just take on it is there's no Medufa goals, so there's no incentive to go faster. The FDA is by nature and by training a risk averse agency. And so they will always default to the more like, yes, we're going to regulate it, higher class, whatever it is. And they don't, because there's no opportunity for interaction in it, they don't, a lot of times it's a black box review group dependent, is they it goes into a black box and comes out with a final decision that you now have to act on and it's in writing. The FDA allows you to self-classify. So if you have a good reason to think you are class one or not a medical device or something, and unless someone is beating you over the head that says something you need a direct response from the FDA, why not self-classify with the justification? Um, the only time I've seen it be super like actually helpful was in the is this a de novo or is this a 510K? Because but they've since updated the Q sub guidance to be clear that you can ask that question in a Q sub. The previous Q sub guidance was a little bit more vague, and a bunch of FDA groups would say you have to submit a 513G if you want us to answer that question. But now they've provided examples where they actually can answer that question in a Q sub, and you can ask not just are we a de novo or are we a 510K? You can also ask 10 other questions and not and make it a useful Q sub and discuss it with the FDA. So I'm very much anti 513Gs unless somebody is tying your funding to it, in which case do it and be prepared to have to wait a year.
Yeah,
So
I did have FDA say because they said, and Lee says in the comments, many folks comfortably ignore the 513 deflections by FDA. And I had one, like the AD was like, no, 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 we've gotten really good. We're getting our answers out within 60 days. Trust us. And I was like, okay. Didn't happen. It was like a year later. I think the worst one I had was almost 2 years. And we finally just said we're going to withdraw it because we need to actually have the file out of FDA's oversight. And then within a week, we had the response. So it was almost like, okay, we're 2 years in. We're going to withdraw this because we just are going to submit whatever pre-market submission. And then FDA made the decision. But I think the legal reasons Grace brings up, she says there are legal reasons behind this decision. I think or for the non-medical device, if there was one that was like, we need to do a 513G because Amazon needs to know that, like, have some sort of letter from FDA that says this is either class 1 510K exempt or that this is under enforcement discretion. And so they ended up getting that, but man, it took a long time. And it was just like people, companies are losing money, right? Like they wanted to be selling this thing, and I was like, why is everyone else able to sell stuff on Amazon that looks like a medical device? But
so when Amazon would ask that, it was actually their AI that was generating that
no
request.
way.
And if you could get on the phone with someone, you could usually get what they actually needed to bypass that, and it wasn't usually a 513G. And shout out to Silva Krazan, who was ex FDA and went in to be the Amazon medical device kind of regulatory chief for a while. She's not still there, but she was great. But yeah, they had hired her out there. She was super like, hey, Silva, this doesn't make any sense. This is clearly not a device. Why are we getting asked these questions? Then she'd be like, please fill out this one pager so we can put it on our records. You're ex-FDA. You're qualified to make that call. And I was like,
Yeah,
cool. And so like that's what they needed. Um,
mistakes were
but
made. All
the
right, should we talk
other,
about? Oh, go
real
ahead.
quick, 513G, 1 year later, got a, hey, please submit an RFD.
No!
That I've never called Ken Skadacic quicker.
You're just on speed dial on your
I was
phone.
just like, Ken, I'm losing my mind. Please talk me off the ledge.
Oh
So
my gosh. I'm so
I've been
sorry.
I've been tempted to call Ken for a thing or two. Is it usually pretty beneficial? Can he
It
like pick
makes
up
your
the
heart
honestly,
call?
it makes your heart feel better. Like
it makes you.
Yeah,
it does, yeah.
more like a
I would
therapist
say,
kind of thing.
yeah, he's an industry therapist. No, he's actually. I think he does a great job of getting cutting through some of the BS of like how you have to maybe position certain things because there might be a predicate under review or the FDA is trying to not say too much, but we're all reviewers. You generally want to guide the industry in the right direction. You're limited in what you can say. Ken will usually kind of cut through that, go behind the scenes and go, okay, this is what they really need to tell you, but they can't, and kind of help with that. He's not going to like,
He was not going to give you confidential information, but he'll be
right.
like, yeah, just
Yeah,
yeah,
breaks it
stay the
down,
course.
and we'll organize a meeting that might need to happen between your company and maybe the division director instead of the review team if things to get are stuck for reasons unknown or maybe it's a personality issue type things. He'll bring in the right players. So it's not like a get out of jail free, but he will make sure that you have an opportunity, a better opportunity to explain your position with the group. And also, he's just like the nicest human being ever.
Yeah,
So
he
it's nice
is.
to keep up with him from time to time.
Yeah.
I do feel bad because every time I talk to him, I'm like bitching about something. But kind of the point of this podcast too, I guess.
I mean, it's yeah. Oh, RFDs. Maybe I'll come up with another flowchart for those. I did see Joshua Christ added to my flowchart
Yeah.
about like how much time do you have, and then it goes to RFD. So might need to update that. The let's talk about the reorg. I didn't know what this. Yeah, tell us, Matt.
I tried to read it, and it was a lot of just like names of places, and I dumped it into my little AI agent. And I was like, "Can you make heads or tails of this?" And it gave me some stuff, but I didn't really trust it. And I was wondering if either of you had gleaned
I
anything meaningful from there.
I thought there were a couple of meaningful things that I pulled out, and then I also saw David Fillmore, who's got MedTech Strategist, Market Pathways, had a post about it too, and he's if you don't follow him on LinkedIn, you should. He's great, but that they were going to consolidate some of the programs like orphan products and women's health and some of the kind of cross center, like, hey, we want to make sure that we're having a focus on this, but pulling them out of the centers and making them more FDA level. So pulling them up, which it's part of the efficiency programs of Doge and things like that is to do that. Conceptually, it seems like that could be a good idea to make sure it's like a broader focus, but on operationally, it's like it almost you want to have both. You still want to have like it's odd to have an orphan product center above CDRH when the rules for orphan products in devices are significantly different than the rules for orphan products in drugs. So, like, how do we get there? We've talked before that the HED process is already kind of challenging. Um, so maybe this fixes things. Maybe they do make HDEs a better pathway again. So I think it's too early to tell if this was a good reorg or a bad reorg or just a reorg for the sake of reorging. Um, I did. I think one of the other things you know, they were talking about doing was, and this came from David's post, was I think it's officially written down now that they're going to not have inspectors be specialized,
Right.
um, which I know because one of our clients had an inspector, and the guy who came in was a marine biologist and was used to looking at seafood safety audits and came in for a medical device audit. So they are really generalizing the auditing folks to be able to do any sort of audit, and I think that's like officially, even though they've been doing it, I think it's officially part of the this reorg is to generalize that, which seems insane.
I always thought that was the case. I always was like, yeah, they might come in from a chicken farm and then they're going to come to a medical device with like, chicken poop on their boots. But like, that sounds like it's now going to be official. So,
Yeah, I remember meeting some of the field safety officers like who would then kind of move to DC to go work in the as reviewers. And the ones that came to work in CDRH tended to be biomedical engineer, like
right.
device had focused their career on doing device audits. But maybe they only did that if they had the right people available, they would do that. But if they didn't, they would send the chicken farm person. So, but I don't know.
Yeah, I'm very interested to see what happens with the reorg. I mean, especially someone was saying, oh, this is kind of they're finally saying, yeah, what happened with Doge is going to be formalized, right? Like we got rid of all these people, and the reorg is to fit what happened last year. I always am worried when you say or they say things like, we're going to consolidate women's health to like with all these other things, and I'm like, I know of a group at FDA that they were all riffed because the word inclusion was in the name of their group, and it housed like the pediatrics, the like women's health, all of these things, and it was just like, oh, I wish they had asked them like, what do you guys do? Instead of saying, oh, there's the word inclusion, you're all fired. Um, Woof. Do you want to talk about user fees? Because that's money is always important to talk about.
Yes. Matt, you put this in, but I can
I can
mention it
I
because
can give
I,
the big
yeah,
picture,
Yeah.
which they posted. They have all this math that I kind of skimmed over and look at the actual numbers of it. I think really big picture, it looks like submission fees for the device space are raising by just about 10%, and then I think for the facility registration fee, I think that's a 20% bump. So that's the big picture view of it.
I was curious. Does this because this is all part of Medufa 6, and that officially has to go through Congress to get like passed. So that's not going to happen before October 1st. So is this going to like, are they going to bump the fees separately and then argue about the rest? Or like basically, should I be really pushing my clients to get submissions in by September 30th, so they can save 10% discount? I was kind of curious about that. So I don't know.
Matt's playing Snake on his computer.
Yeah.
What were you
I don't know.
starting? Okay. I thought he was looking something up. I was like,
Yeah,
oh,
me
he's
too.
gonna tell us. He's gonna drop a
Um,
truth bomb here.
the other, while looking up the reorg insights and getting pushed to David's posts, David Fillmore also had a post about this right below it that I saw. And I thought this was super interesting too, that the only way that the FDA was allowed to increase user fees was if they hired 75 people in FY 2025, and they've claimed that they did, but they also fired everyone. So I don't know, but they also fired everyone at FY 2025. So I don't know, like, was there not a caveat for like, you can't fire 75 people and rehire 75 people and have it count? Like, is that what they did? I thought that was like,
That sounds very
there,
FDA, doesn't it? Or
it
very
does.
government of like, oh, we hired so many people because we riffed them and then we brought them back and then we.
It just seemed very cynical, honestly, to get as a way to get by this, but maybe I'm also not a policy lawyer, so maybe I'm just misreading it.
Oh, maybe we need to have, two things that have come up in the past 10 minutes. I feel like we need like a FDA lawyer to come on here one day, and we also
Call
need like a
Phil.
former inspector. Oh yeah, Phil could be on here. Okay,
Yeah.
Phil, we're gonna put you in the shout out.
Yeah.
Um, all right,
So
should we?
my game of Snake told me that Meduva
Oh,
5 lasts through 2027. So I think Meduva 6 is going to start October 2028. So I think these
Okay.
2027 numbers should be locked in, as I understand
okay,
it.
good
Okay.
man. Is that
Gotcha.
also maybe we'll be paying for pre-subs then too?
Probably.
So,
Yeah.
all right. Let's talk quickly about the human factors guidance. Because I think the information from the town hall or the whatever the panel went up. Um, yeah, what are you seeing with that? I have some things to say too.
We've got a couple of 510Ks that are going in right now, and the new eStar has all the new guidance information in it. So I know it. Matt put in that it officially goes into effect on the Saturday 8/1, but for all intents and purposes, it went into effect the second the new eStar came out, because you can't actually submit without going through a lot of the new human factors required information.
You can use the older eStar,
That's true.
but I
They
agree. Like
will,
what? Yeah.
yeah, and the FDA will
Um,
shame you.
yes.
Yeah.
We had one go in last month, and we were like, well, we use the version that has not yet been retired because it was almost filled out by the time the guidance or before the new eStar came out, and the reviewer um, has written we got the file's been accepted, and FDA or the reviewer came back and said send us all your human factor stuff, and I was like but it wasn't, and they were like nope, just send it. I was like okay.
I feel
So
like that's kind of. I've seen that a lot where, like, I've seen questions that were almost verbatim taken from, like, draft guidance documents. We're like, oh, this is draft, so it's
our
not really
current
something they're going
thinking.
to force, but then they're gonna say that's the current thinking. They certainly can ask questions that look a lot like what's in the draft guidance without explicitly referencing it, and then it's kind of
Yeah.
hard to push back on something like that.
What if
I
it's
feel,
draft or final? It's always like which one better serves what they want to see, which
yeah,
makes sense. It's like
I
this
feel
is
like
our
I've
current
been
thinking.
very
That's not our current thinking. This is our current thinking. It's like
I feel like I've been overly negative to FDA this week, but the human factors one, usually we're very supportive, but this, you're catching a lot of my pet peeves. The human factors, we had a submission go in last year, like in the fall, and the reviewer told us we weren't allowed to talk about any of the recommendations in the 2023 guidance because it was still draft, and had us like throw away a bunch of stuff that we had submitted because it was in that guidance and not the 2016 one, but then asked us to reformat our documents so that it looked exactly like the draft um, guidance. And I'm like, I don't want to name the names, but like, I had to talk with their manager. I'm like, you see what's going on here, right? And they kind of did yeah, just do what we ask answer. And that was extremely frustrating. And it took a full year through a PMA review to get it back to the agency, redo like a human factors, like go from 15, redo it with 60 participants instead because they wanted different user groups. It was an insane thing for a very simple surgical implant. Like that medical school should have qualified uh, the thing. It was crazy. Uh,
And by the time you got it back in, was like the final guidance out, and they're like, now we need you to update.
yes. And I am not kidding. They tried. Um, we won that argument, uh, but we did
Oh
have to
my
escalate it.
God.
So yeah, I'll share I'll share names in the Patreon
Yeah.
subscription.
Okay. Yeah,
Yeah.
exactly. Go to Patreon for $1. We'll tell you
Uh,
all the dirt is in the Patreon. Let's we're coming up on 10 minutes left. I want Nilo, tell us about Rapid. I'm curious. I don't know what
oh yeah, so we did all this, talk about the RAPID program, which is kind of going to be that connection from breakthrough TAP and the reimbursement folks at CMS. And it was being championed by FDA, and we talked about it at the MDIC conference as well. However, it's not actually in place yet. It's kind of still in draft, and people were getting excited about it, but it is continuing to progress, and it's actually under final review of the OMB, which is Office of Management and Budget, I think. And usually, once things get there, all the actual like program details have been ironed out, and this is just, do we have the money to support this program? So it's almost always the last step. So I think they wanted to officially launch the program on October 1st at the beginning of the fiscal year, and it looks like that's probably going to happen. So, I mean, it's a cool program
Yeah,
for organizing the CMS and FDA component, and kind of continues that total product advisory program tap. So,
that's cool. I like it. Yeah, that's good news because sometimes I'm like, I mean, especially after the news that they were, and we talked about it in previous weeks of, things that McCary had put out on social or getting rolled back, and it was like, it's nice to see programs like that kind of be moving forward. So,
yeah.
yay.
And like certainty and commitment to like things is really helpful for, what they say 90% of medical device companies are 20 people or less or something like that. So like small companies can't
Yeah.
have the rules flip or programs disappear because you put a lot of effort into trying for them or going toward a goal. And if they just go away, it's like we might not survive that change. So it's good when they stick to things.
Yeah. T-set
Cool.
and tap.
Yeah.
But okay, let's. This is a random hemodialysis blood tubing set. There's a new guidance for that. It wasn't out. Like it was weird. I clicked on it yesterday and it was like, this is a broken link. But now it's working. And I always check what new guidances are coming out because I'm a nerd. And this one gives you a lot of information. It's a device specific guidance. So when you're going through your eStar and you're going to have to be submitting things like this, it tells you like what performance testing they want, what sort of biocomp you need to do, sterility, shelf life packaging, labeling. And so those various sections that say, is there a device specific guidance or a special control? Now there is one. So I love these guidance documents, not gonna lie, just because it probably saves them a lot of pre-subs as well of like, what testing do we need? Is this acceptable? And they're just like, they finally put it in a guidance. So this is for different blood tubing, dialysis tubing, infusion, and venous blood tubing. So anyway, yay, love it. Love that for us. And then There were two updates for the, I don't know, I always look at the CDRH new as well as the press releases. When there was an updated list for companion diagnostics, I actually don't know if this is like a new website, like if they put a new, totally new thing, or if they just updated it. Unclear. But that one is for in vitro and imaging tools, and it lists it's like the AI-enabled devices that they've cleared. This would be the list of companion diagnostics that are available and their associated products. And then there was also an update to the FAQ page for radiation emitting products and bringing those to market. Again, not sure if it's brand new or if it's like just an update because all they say is it's updated, but that could mean that they're breathing it into life. But yeah, I'm sure there's an expert out there that says, of course it's been out there for a long time, but now there's an FAQ for that. So I like seeing stuff like this, new guidance, new yeah, pages that have links and to help people really understand what is the regulation around their device, or if they have questions about it, where they can go and get more information.
I I don't know, Matt, you work more in diagnostics, but I did not know that this existed, this list, so it might be new. And honestly, you know, working with IVD products and explaining to the FDA the different, it's tough for a regulatory agency to like handle what is a companion diagnostic or like a screening tool and what the bar should be for those, like versus a full on and diagnostic and what is good enough. And so having a library of where they've made similar decisions, I think would be actually, this is going to be super useful. I'm sending it to my team now because I don't think I was aware of this one.
This is why
But
we have this weekly thing. This used to just be
keep it
for
on.
me and Nilo to make sure we're not slipping.
Still a
And
lot
now
of
we have
that.
guests, and it's mostly that, actually, yeah. And yeah, Matt, I have to confess, like we are so bad at putting things in until like a few hours before, and then our guests, I think, as you said, they get a little nervous and they go in and populate it for us, and it's just like, oh, this is great.
It's a good trick, right?
Thanks,
I did
Matt.
that on purpose,
We
didn't you?
have conned our way into getting people to do our jobs.
Over here biting my fingernails off, and I'm like, what are we
Oh
going to talk
man.
about? What am I
Yep.
doing?
Nobody knows. Nobody knows what we're doing. So, last thoughts? Anything from the chat group and our three listeners?
On the companion diagnostic front, I don't know if you talked about this because I don't think it's super new, but there's this Enhancing CLIA Act
Mm.
um, that is about LDTs and how they're going to be regulated. And I haven't gone super deep, but my high level understanding was that they're trying to make it really explicit that they're regulated by CMS under CLIA and not by FDA. But then they have all this other stuff where it's like, well, you can get this supplemental affirmation by these like established third party review groups, and that's totally voluntary. Um, and one of the third party groups is the FDA. And then you get these benefits by going through that process. Some of them relate to companion diagnostics. So I think they're trying to push all the companion diagnostics through the FDA review if you want to really get that claim. And so I think they're trying to find this alternate way where if you're an LDT, you can do it, but you have to go through this third party, and then you're almost like, to what degree is it really voluntary? There's going to be some like reimbursement tie-ins for that as well. And then I just wonder, is this another way to kind of slide into FDA or potentially other third parties doing more of these reviews of LDTs? So I'm kind of keeping an eye on it, but I'm not sure how far along. Is it really going to happen? But it's very interesting what they're mapping out there.
Interesting.
I'm going to have you back
I know
on
nothing
to
about
explain it
IVDs.
to.
I know exactly. I'm like, I know what LDT stands for,
Yeah. I,
but that's
yeah. I've gotten into like the diagnostics and like things on the IVD where it is clearly regulated by FDA, but the CLIA and LDT like nuances and things like that, I rely on other people on our team to understand that. I haven't gotten into it too much.
It gets complicated fast. And then there's all this stuff about like New York State and having it reviewed by them, and that's this whole other mechanism that I still know nothing about.
yeah. I've heard about that too. That if it goes through the state, there's anyway. Matt, how do people find you?
Find me. I mean, I'm on LinkedIn. I very occasionally post, but not often. But you can reach out. This
Love
was
it.
great. Thanks for having me on.
Thanks for
Yeah,
coming on.
absolutely.
And yeah, we'll try and keep up next week again. Thanks, everybody.
Thank
Bye.
you.
Bye.
Hold on, rewind. What did they say? Allison and Nilo just winging away. Regs and guidance, we'll try our luck. Just two folks out here trying to keep up.